Bendock from the Department of Neurosurgery and Radiology at Mayo Clinic in Arizona.
And I'm Dr. Brian Chong. I work with Dr. Bendock.
Thank you for joining us today for another edition of Mayo Clinic NeuroChat. Today we're talking about brain aneurysms, their treatment, and 3D modeling. We will be taking your questions throughout the broadcast, so make sure to post your questions to the comment section below. So I thought, Dr. Chong, we'd start out with just sharing with our audience. Some of them may not know what a brain aneurysm is. Brain aneurysms are, as you and I both know, are outpouchings on brain vessels. They tend to occur in about 1% of human beings. Some families are at higher risk for having more of them, but on average, about 1 to 2% of the human population has an aneurysm. They tend to form in people's 30s and 40s, and they often rupture in people's 40s and 50s. The only other animal I know other than Homo sapiens that gets aneurysms is the Galapagos turtle. I'm not sure if you're aware of any other species, because they live long enough. I think it's the price we pay for living a long time compared to most species. And it's really wear and tear on the brain arteries that I think results in brain aneurysms. Brain vessels sit in spinal fluid. They're not invested with a lot of tissue around them like other body vessels, and the brain is a organ that gets a huge part of the blood flow from the heart. About 20% of blood flow from the heart goes to the brain, so brain vessels carry a greater load, and we think that plays some role in why people form brain aneurysms. We know there are a number of risk factors, and Dr. Chong, perhaps you can share with us some of the risk factors and why some people are at higher risk for both getting aneurysms and also for rupturing an aneurysm.
Sure. So while some brain aneurysms are inherited in families, that's actually pretty rare. The vast majority of brain aneurysms develop spontaneously in a family member, but certainly if you have a first-degree relative, that's say mother, father, sister, brother with a brain aneurysm, we worry that perhaps you have a brain aneurysm as well. So sometimes we screen those patients. In terms of risk for rupture, generally we like to talk to patients about good vascular health. And so if you have a brain aneurysm, a weakness in the wall of the blood vessel, the last thing you want to do is turn the pressure up in that blood vessel. So hypertension, high blood pressure is one risk. The other risk we worry about is just things that are hard on your arteries. So smoking, obesity, lack of exercise, poor diet, those are the general risk factors that we worry about.
You know, I've been very interested in the whole idea of familial aneurysms and what the impact that it was. And there is some data now suggesting that up to 20% of people who rupture an aneurysm have some family history of brain aneurysms. So it's a thing that in the heat of battle, in the heat of the moment of a rupture, we don't often pay a lot of attention to. But as one digs deeper, there is a genetic influence on aneurysms. I typically recommend MRA for first-degree family members with in families where there are two family members with an aneurysm, non-contrast MRA, so we keep the risk down.
Sure.
And another thing that's interesting is when you have a family history and a connective tissue disease, you know, one of the areas where we're seeing a lot of brain aneurysms is in families with polycystic kidney disease. I know you and I have shared patients in that population. So when you have a connective tissue disease, a disease that makes the body tissues weaker, that may increase the risk. And if you have a family history of aneurysms and connective tissue disease, that risk may be even higher. And if you add smoking to that, now you're talking about big trouble. So smoking is really a big issue, I think. And
absolutely.
if we do nothing else but go around the country stopping people from smoking, we probably could make a big difference in outcomes for brain aneurysms.
Right.
So Dr. Chong, what are your thoughts? You know, you obviously bring a lot of strength in imaging in this field, and you've really enrich our aneurysm center with that background, and what are your thoughts on imaging of brain? What is the best modality? What kind of for just screening, for example? What would you recommend?
Yeah, so Dr. Bendock mentioned MRA, which stands for magnetic resonance angiography, and it's a type of MR scan. I would say that that's probably the best way of screening patients for aneurysms. It's able to detect very tiny aneurysms as small as 1 millimeter to 2 millimeters. But some patients can't have MR scans. They need to consider then having a CAT scan, which is a X-ray type of scan that injects X-ray dye into the arteries, and we can make very similar images with that with just as good sensitivity to detect the aneurysm. Then finally, if we find the aneurysm, we often choose to do what we call a catheter angiogram, where we place a catheter in the artery and inject X-ray dye. And that's probably the highest resolution type of scan that we need. We generally get that when we know we have a brain aneurysm to treat and to help us make a model of that aneurysm so that we can plan the treatment very accurately.
Yes, that's a very good point. And one of the questions I get asked often is, what are the symptoms of aneurysm rupture? As you know, headaches are very common. And so the question is, which type of headache should prompt further investigation? What are your thoughts on that?
Well, that's an excellent question. As Dr. Bendock said, many patients have headaches, but those generally don't always have to be concerning. The type we're looking for with a brain aneurysm, we classically describe as the worst headache of your life. I often tell patients that these come on suddenly. We call them thunderclap headaches because unexpected on a nice day, sometimes you'll hear a big boom of thunder.
Right.
We typify that as the classic headache that you get.
Yeah.
We also listen for patients describing the worst headache of their life. So headaches that come on suddenly and are immediately 10 out of 10 in intensity. We're not talking about the type of headache that you wake up with that may be mild.
Right.
By the end of the day, you'd say, wow, this is the worst headache I've ever had.
Yeah.
These tend to be rapid in onset and very intense. Sometimes they're associated with other symptoms like nausea and vomiting. Sometimes patients prefer to be in a dark room. All these associated symptoms with these bad headaches tend to typify perhaps there's an aneurysm leak.
Right. Getting checked out in an emergency room can save a life. When you have that kind of headache, most headaches are gradual in onset.
Exactly.
And so I find that the most important question to ask patients is, how did your headache start? Did it start out gradually and build up, or was it a sudden onset like an explosion? And if it starts out like an explosion, that is very worrisome and deserves further workup, usually with a CAT scan, and sometimes a lumbar puncture is needed to check the spinal fluid for subtle signs of blood.
Exactly.
So once a aneurysm is found, let's say let's talk a little bit about the treatment options. As you know, you and I have been in this field for a while, and it's been wonderful over the last 20 years watching our treatment options expand. And I think we have more tools today than we've ever had. And in fact, one of our challenges today is to pick the right tool to match the right patient. I think we're getting smarter at that as a specialty. And so what are your thoughts on that in terms of the current treatment? Maybe we can both talk about that a little bit for our audience.
Yeah. No, I would entirely agree with Dr. Bendock's comments. It's an exciting field to work in this day and age because our tools are so different than they were even 5 to 10 years ago. One of my colleagues, another surgeon, likes to say you have the best tools in the field. So they're fun tools to work with. But in terms of what they specifically are, in general, we have two different ways to approach an aneurysm. One way we think of as a less invasive way, and another way we think of as perhaps a little more invasive, but often very appropriate and very effective and very needed. And I'll let you address that second option, which we classically call an open surgical approach. The other approach I'm referring to is what we call the endovascular approach. And endo means inside the blood vessel, so endovascular. And we take two strategies with endovascular treatment. We go through the artery in the groin and we feed a catheter up to the artery in the head, and we either try to plug the aneurysm up by going inside the aneurysm from the inside, or we try to block the flow to the aneurysm but maintain flow to the rest of the brain. So in doing that, we can either place something inside the bag or the sac, if you will, or we can exclude the sac and divert flow away. I tell patients it's much like taking a leaking balloon and either trying to stop the leak by going from the inside of the balloon and filling it up with something, or to take the air or the blood in this case and prevent it from going inside the balloon.
Right. And on the surgical side, we have a technique called clipping, where we can place a clip on the neck of the aneurysm. This is actually an example of a clip that you can see it here closing, and the clip, and this is just a model of an aneurysm. I'll show you here. I don't know if our audience can see it very well, but this is a bulge on a brain vessel, and you can see here we can place a clip across the neck of the aneurysm and close it, just so. So this is a treatment, as Dr. Chong said, we can come from the inside with a catheter and put coils into this aneurysm, or we can place a clip on the aneurysm. I don't know if everyone can see this very well. It's a bit small, but the idea is you can treat it from the outside or inside. And one of the things we've been working on, Dr. Chong and I, is figuring out how to decide on the best treatment option. We'll talk about that in a little bit, about the simulation, both with physical modeling, whether it's creating a physical model, this is a blown up model, but a physical model of an aneurysm, or a computer simulation so we can be very smart about treatment decisions. Now, we're always trying to advance both treatment options, and we've come up with many innovations on the endovascular side, including sometimes we go through the radial artery, for example, as a way to make it even less invasive. We have now imaging techniques that allow us to see things in 3D and so on. And we use some newer types of coils that are advanced, and the stents are also getting better. On the surgical side, we're also trying to innovate things by becoming a little bit less invasive. We've developed an approach where we can come in through an eyebrow incision. We didn't develop it ourselves, but we've modified it a bit to make it a little bit more effective. And we can actually come from above the eye and get to an aneurysm like this in a less invasive way that can be very cosmetic. So it's important these days. In the old days, it used to be that you treat an aneurysm, it was just important to get the patient through it and make sure they're alive at the end. Now, we want to make sure they have quality of life, they're happy with their cosmetic result, they're happy with their functional outcome, and that they have a durable result. It's important also when we treat an aneurysm that the aneurysm be imaged after the treatment, and people need close follow-up long term. How we follow patients obviously differs depending on how we treat them and so on. But I think that this kind of modeling has really helped us in terms of understanding how to treat an aneurysm. I know, Dr. Chong, you've been very involved on the computer simulation side, which is equally, if not even more exciting, in terms of being able to guide us. Can you tell us a little bit about that?
Absolutely. So maybe just a contrast first. Dr. Bendock has some printed models out here, 3D printed models of aneurysms. And as you can see here, this is the aneurysm, and this would be the vessel coming into the aneurysm, and this would be the vessel flowing out of the aneurysm. So this type of bubble is what we're talking about. An aneurysm such as this is very difficult to treat, and what we're talking about in terms of simulation is allowing the surgeon to actually choose the right tool for the right patient at the right time. So using these types of 3D models that you can actually visualize and look at is one approach which is very, very useful and often complementary to the approach that Dr. Bendock is referring to that we've been doing some work in together. The other is the computer simulation, and this is a way of basically taking a patient's aneurysm, and rather than having something that you can hold in your hand, which has great utility, making a virtual model of this particular aneurysm that's very accurate. And I want to emphasize that that is that particular patient's aneurysm that we're looking at. So we take their CAT scan or their MR scan, and we create a high-resolution virtual model. Then what we do is we take a device. Dr. Bendock referred to coils, which look like little platinum slinkies that we can pack the inside of this aneurysm with, or alternatively, we can plant a device that goes from the feeding artery down here, travels through the aneurysm, and implants on the far side of the outflow vessel. That looks like a stent. A stent is just a mesh tube, and we call that a flow diverter because it diverts flow into the artery and not into the aneurysm. Again, the question is, which device is better? Which is going to serve that particular patient well? The other thing is these devices come in multiple sizes and shapes. They're very expensive, and obviously if you put the wrong device in that doesn't work, that's not a good thing for the patient.
Sure.
So the computer simulation involves simulating the patient's aneurysm, making a virtual model of that aneurysm, and then simulating the device, whether it be a flow diverter, a stent type object, or multiple tiny platinum coils. And we can actually simulate placement of those coils or the flow diverter in that specific patient, which is obviously very useful for us as operators. We see what our plan is going to look like ahead of time. The other thing this allows us to do is to actually plan 1, 2, or 3, or 4 different options for that particular treatment, for that particular patient, and see which one turns out to be the best in our opinion before we actually do that surgery in that patient.
I think 2 other benefits is the idea of practicing the procedure before it's done, and I think that can lead to better outcomes. And for patients who live very far from Mayo Clinic, they can actually send us their MRA or angiogram, and we can try to print the aneurysm and do the operation, so to speak, before the operation or the procedure. And I think that is very valuable to give the patient a lot of insight, so we get to know the patient, so to speak, before they even come to us. I think that's very valuable. So along those lines, this actually represents what I call a giant aneurysm. Giant aneurysms are 2.5 centimeters or greater, and I think it's worth spending some. We've already mentioned some of the treatment options. These are the most difficult type of aneurysms. They're very dangerous. They can be very life-threatening. And you mentioned stents. I mean, that has been a big revolution in terms of our options for aneurysms. And when stents, flow diverters are not an option, there are things like stent-assisted coiling that we can do. And I was going to briefly mention just the idea that if those things are not options, or if those options fail, then bypass and direct surgical repair can be an option. So I think it's one thing that's great about our center is that we present cases in a combined conference where we invite our colleagues, anybody who's interested in aneurysms at our center comes and attends that conference, so we get that group input, so we hopefully give patients the very best advice.
Absolutely, and I think Dr. Bendock made a very good point there, and that is the more tools you have in your toolbox, then the greater likelihood you're going to be able to offer a patient something that they specifically need. So having all these different tools, having all these different perspectives, and having all these different ways to simulate the repair ahead of time to improve the patient's outcome is very useful.
You know, we've talked a little about ruptured aneurysms, but another question that comes up increasingly more often these days is, what about when an aneurysm is caught before it ruptures? When should it be treated? And that's a complicated question. The larger the aneurysm, the more risk it poses to the patient. The younger the patient, the greater number of years the patient is at risk, so we're more likely to treat an aneurysm the younger the patient is. And we also look at risk factors. For example, patients who have an aneurysm and smoke have a higher risk of rupture. Patients who have a family history of rupture, patients who have a family history of connective tissue disease like polycystic kidney disease or Marfan's disease or Ehlers-Danlos syndrome, those patients are probably at higher risk for rupture. So increasingly, I'm hoping one day we'll have a computer equation that factors in the genetics, the risk factors, and your computer simulation, the hemodynamics, and hopefully we can come up with an equation that would help us individualize that risk-benefit assessment. What are your thoughts on that, Dr.
No,
Chung?
I think that's our vision for the future. As a team, we really look towards the future, and we use technology to the benefit. I mean, our goal right now is the simulation that we're talking about is we've been simulating structure in these giant aneurysms. We've been simulating how different devices interact with structure or the biology. And I think eventually our goal is what you're talking about, and that is simulating biology itself.
Yes.
And being able to predict how our bodies are going to respond to disease states and some of the things we hope to do to change the disease states.
Yes, that's fabulous. Another question that comes up is when somebody has an unruptured aneurysm, which center should they go to, and what are the characteristics of that center? Give me your thoughts on that, maybe I'll share some of my own.
Yeah, I think, again, the key is we use the phrase to have all the tools in your toolbox. Well, you have to have all the complementary team members you need as well. So having one good operator or two good operators who have a lot of experience treating aneurysms is fine. I mean, that's obviously desirable. But having the comprehensive team to look at the whole patient, everyone involved from when that patient walks in the door to when they leave. Repairing the aneurysm, as you alluded to earlier, is only the first step.
Yes.
You know, now we're looking at how to make that recovery period for that patient really, really successful on every level.
Very good point. You know, I think one thing we've established, Dr. Chong and I, over the past 2 years here at Mayo Clinic Arizona is 24/7 fellowship-trained open vascular and endovascular coverage, which is really, I think, necessary. And I think patients should look for the history of expertise at the center, the volume of cases treated, the outcomes, and that team approach. And one of the things we care about deeply at Mayo Clinic is that team model and that team approach. And Dr. Chong and I are in clinic together every week. We have a joint conference that we run together where we invite our colleagues to discuss cases. We're often working on simulations together. So it really is a deep commitment, I think, that one has to look for. And I think that's something that I really enjoy sharing with you. So.
Yeah. I think what's interesting is some of the best ideas, some of the most innovative ideas we've had have come from people outside of our field sometimes.
Yes, true.
And that type of collaboration of multiple specialties has been very useful for us to innovate some of these new things we're talking about today.
Right. For some of our students on the line now, we have a research fellowship program, and we often have many students with us. And I think that students also keep us on our toes. They keep us thinking of new ideas, and their creativity actually adds a lot to our team.
We have a question from a Mayo Clinic Connect member, and he asks, how does one go into the field of medical 3D modeling? Would it be better to pursue a PhD in biomedical engineering, or would it be better to go to medical school to have a career in 3D modeling? Do you work alongside PhDs or largely MDs? What would your advice be?
I think that's a wonderful question, and I think in a nutshell, not knowing who asked the question or what they're like from a people perspective, I think my advice would be to follow what you're most passionate about in terms of whether you want to pursue the MD or the PhD training point. I think one of the points we just made is about teamwork and collaboration. And I think it's very difficult in this age for one individual to have all the breadth of knowledge necessary to innovate in this field. So to be specific about your question, we've worked with many PhDs, Dr. Bendock and I, we've worked with many MDs in collaboration. The perspective is different on each. And to be honest with you, both of our simulation algorithms that we're talking about wouldn't be possible without the collaboration of our PhD colleagues.
Yes.
But the flip side of the coin is often our PhD colleagues need the clinical perspective.
Yes,
They need
good
to
point.
be able to redesign their tools or fine-tune their tools to make it more clinically relevant to ask a specific clinical question. So one of the strengths here at Mayo, Arizona is we have a very strong collaborative relationship with our in-house PhDs. In
Yes.
fact, we're sitting right here in this wonderful lab that Dr. Bendock has, and there are a plethora of PhDs here. We also collaborate with many of our colleagues down at Arizona State University in biomedical
Yes.
engineering.
Yes.
So collaboration is key, whether you choose to be a PhD or an MD. Pick which one is going to be most passionate for you.
It's a team sport. You have to decide which position you want to play. So that's
Exactly, exactly.
Great. We have another question from a Mayo Clinic Connect member. They have an intracranial internal carotid artery aneurysm, and they're wondering, how do you define large? What is a large aneurysm? And secondary to that, does a large aneurysm require intervention, and how long can it go untreated?
Yes. The question, there is a classification scheme that defines large aneurysms as greater than 10 millimeters to about 24 millimeters, and anything 25 millimeters or above is what we call a giant aneurysm. But this nomenclature is somewhat arbitrary because we know that the average size of rupture worldwide for aneurysms is about 7 millimeters. In fact, it can be smaller for some aneurysms. For example, there's a type of aneurysm called the pericallosal aneurysm where the average size of rupture is 3 millimeters. So I think the word large is helpful to some degree, but it is a semantics issue, and I think it's all relative.
I would agree.
And whether, I'm sorry, let me just say that whether that a particular aneurysm needs treatment or not requires a discussion with an experienced team, and I would encourage the viewer to seek out consultations, perhaps even several opinions.
All right, we have another question from a Mayo Clinic Connect member. They're 3 weeks into a cerebral aneurysm rupture with coiling and facing some symptoms with headache, fatigue, loss of appetite, and insomnia. Do you have any recommendations for what they can do to help combat the symptoms?
On this program, we can't give specific advice because all medical advice is based on a history, physical examination, and review of imaging. That being said, the symptoms that are listed are very common after a rupture, and there's probably several reasons for them. The blood that leaks around the brain when it breaks down, can cause nausea and headaches. But obviously, more serious causes of headaches need to be ruled out by the treating team.
And any final words you have for individuals who are dealing with an aneurysm or caregivers who have somebody, what would your recommendation be to them, or words of wisdom?
Right. So I think, first of all, detection is very important. If you have a family history of brain aneurysms, or you have suspicious headaches, it's very important to be evaluated by an experienced team. Second is there's never been more hope for patients with brain aneurysms. The treatment options are better than ever, and so I think there's a lot of hope, and many aneurysms can be treated and cured.
Actually, sorry, we have one more question that just
Sure.
came in from Facebook, and it is an important question. Are cerebral aneurysms hereditary? Is there any kind of hereditary genetic link to aneurysms?
As Dr. Chung mentioned earlier, most aneurysms are what we call sporadic, but there are genetic influences on aneurysms. So there are genes that can make it more likely for one to have an aneurysm. There are certain families that have a higher risk of having an aneurysm. In fact, in the general population, aneurysms occur with about 1% frequency. whereas there are some families where the risk could be as high as 30%. In those families, we recommend familial screening with MR imaging. So on that note, thank you for joining us today for our discussion about brain aneurysms, joining Dr. Chong and I, their treatment and 3D modeling. This discussion will be on Mayo Clinic's YouTube channel and our Facebook video section for future viewing. Thank you for joining us and have a great day.
Bye-bye.